So my talk today, Everybody Hurts, the personal and political ramifications of trauma and its treatment for women. So I'm going to cover a broad spectrum here, and I have a lot of slides. I'm going to go through it fairly quickly, but hopefully it will make sense. And you have the slides as well. So I'm going to do basically three things this morning. I'm going to describe the consequences of trauma, especially for women. I want to identify the advantages and disadvantages in providing evidence-based treatment for traumatized women. Two broad categories of, when we think about trauma, two broad categories. There are the single incidents, and then there's chronic or repetitive trauma. And that's important for us to hold in mind because the consequences of chronic trauma are pretty broad. And most of the research has been on single incidents. So you'll hear that coming up again and again as we talked this morning. But first, let me give you just a really quick idea of the prevalence of trauma. And I'm going to start with the US data. It's a national comorbidity study. And basically, they found that a large proportion of individuals, both men and women, experience at least one traumatic event. And there's some research that says it's as high as 90%. So it's always hard to know exactly how much trauma is out there because it depends on people reporting, and not everyone's going to report. But the incidence is very high. And the majority of people actually report two or more. There are real differences in between the kinds of traumas that women experience compared to men. So for women, the trauma, it usually involves someone that they're close to. And for men, it's kind of a range of sources of traumatic experiences. There was a national prevalence study in Canada 20 years ago, and they found that 50% of women experienced at least one episode of violence in adulthood. So those stats are high. And then there was a study that looked at the prevalence of child abuse in Ontario. And this is pretty representative data. There's been lots of research looking at the prevalence of child abuse. And males tend to experience more physical abuse than females, generally. Females experience more sexual abuse. But the most prevalent form of child abuse is actually neglect, and it has a profound impact. So this is data that is from 2011 in Canada, and these are police-reported incidents of violent crime. So it's important to kind of hold that in mind. So it's just looking at what was found by what was reported to police. So there's lots, certainly probably the majority of trauma doesn't get reported to police. But what's important here is just to see that there are two things here. One is that in terms of violent crime, there's not really a huge difference between men and women in terms of how often they experience it. So that's one point. And the other is that the younger you are, the more likely you are to be a victim of violent crime. This slide is also the police-reported violent crimes, and it really supports the research that I mentioned a few minutes ago, which is that women are more likely to experience violent crime from someone that they know and should trust, whereas for men, it's more likely to be somebody who is a stranger to them or an acquaintance. And here we see, so this is the victims of homicide, intimate partner homicide, and this I'm sure will be no surprise to anyone here, which is that women are more likely to be killed by their partner than are men. And this is over a period of 20 years. And really, I don't know, that's very interesting, the stats in 1991, but it looks like it hasn't really, it's pretty stable over the last 20 years, which is very sad to see. So what are the implications for women? So for women, what it really is suggesting, this data, is that the biggest threat is within their homes and with people whom they should trust. Okay, so that's a very quick overview of prevalence and types of trauma. Now I want to kind of zone in on what are the consequences of trauma. And this slide is really to suggest that trauma impacts the individual, but it also impacts the family, it impacts our communities and society at large. I'm going to focus primarily on what happens to the individual, and that's what I'm going to talk about now. And really what I'm talking about is the impact of complex trauma. So the impact of that kind of chronic repetitive trauma, which the evidence suggests that, the research evidence suggests that that is far more common than single incidents of trauma. So the first broad category of impacts are emotional impacts. And here you see some of them: depression, anxiety. Those are very common problems. Shame and guilt, fear, anger, affect dysregulation, not being able to really kind of, being very kind of emotionally volatile, easily set off, and having to cope with overwhelming emotion. This is a slide of mood disorders in Canada, and it's not looking at trauma per se, but these data are interesting nevertheless, and I think that we need to think about, is this a reflection of trauma? But what we see here is that women are more likely to experience a mood disorder, to experience depression, than are men. So I would suggest that women tend to internalize their distress more than men. And here we see the rates of depression by age and sex. This is for 2012. And again, this data kind of maps onto what we saw with violent crimes, which is that the younger you are, the more likely you are to suffer from depression. That decreases as people get older, and that women are more likely to suffer from depression in all age groups. So behavior. So complex trauma impacts behavior in all kinds of ways, and these slides, we could spend an hour talking on just whatever is on each of these slides. So this is really flying through this material. But things like problems with addiction, interpersonal problems, being re-victimized, kind of being set up for re-victimization, self-harm, violent behaviors, eating disorders, not being able to be a very good parent, avoiding reminders of trauma. So those are some of the ways in which behavior is impacted by trauma. This slide here, I think is very interesting in that it looks at the number of people who went into emergency departments in Ontario because they've engaged in self-harm, or there was some undetermined self-harm. So it looked like it was self-harm, but it wasn't really certain. And I've circled just this one category here, because that to me is what I really want to emphasize at this point, is that we see again that there's a real difference between males and females. So that females are more likely to engage in self-harm than are males. And it seems as though that younger females there's an even greater disparity between the number of males versus females who engage in self-harm. So that raises really interesting questions. I think that research is really warranted to really investigate those. And here, sort of counter to that, if we look at rates of substance abuse, what we see is that men are more likely, so males, that's the pale blue bar, men are more likely to have problems with substance use. So it seems as though women internalize, and I'd suggest that men externalize. So they engage in more kind of acting out behaviors, and women in more acting in behaviors, if you can understand what those terms and tolerate those terms. And then suicide rates by sex. So here again, what we see is that a real difference between males and females, and that men are more likely to commit suicide than women. So self-harm is not really a suicide attempt. Self-harm is a way to deal with distress. So that's that internalization. And suicide, there's a real desire to end one's life. So that's a different phenomenon. And there are hypotheses as to why there is this difference between males and females. One is that men are more violent. Another is that men are less likely to seek health care. They're less likely to seek help. And then a third that has been suggested is that women are more relational and they're more likely to think about the impact that suicide would have on their loved ones. Okay, beliefs. So having experienced chronic trauma throughout one's life, it's going to impact how you view yourself and how you view the world. So shame and guilt are very, very common, that it's one's fault and it's because I'm a bad person that these things are happening. And then the experience of the world is that it's unsafe and it's really hard to trust other people. People are not trustworthy. So people are going around with that belief system about themselves and about others. Chronic trauma or complex trauma impacts cognition and how we think. So there'd be a lot of rumination about one's traumatic experiences, difficulties concentrating, and there's even research to suggest that there's an impact on memory over age and a decline in cognitive function with aging. Consciousness. So the most extreme kind of ways in which it impacts consciousness is those dissociative experiences, and of course the most extreme version of that are people who suffer from dissociative disorders. So consciousness is another way in which trauma affects the individual. Making meaning out of one's life. There can be a loss of meaning that occurs or a real struggle to make meaning in life as a result of trauma. And then finally, physical health. And there's been a lot of really important research that has come out on looking at the relationship between adverse childhood experiences and the impact on physical health and also on mental health. But the relationship between it's basically counting the number of different categories of adverse experiences in childhood and looking at the likelihood of having every kind of health condition that you can imagine. And the greater your score, the more different types of adverse experiences you've had, not counting the severity or the frequency, but just the type. Were you abused as a child? Did you live in a household where there was a single family? Was there someone in your family who was incarcerated? So just counting those up. The higher your score, the greater the likelihood of having cancer or chronic heart disease, etc. So it seems to be a direct relationship between adverse experiences in childhood and health. And this is research by Vincent Felitti, and if you don't know of this research, and Robert Anda, just Google adverse childhood events and there's a ton of information out there. But this is a model that they created to really try to understand, what are the mechanisms. They've shown that there's evidence for each of these. So adverse childhood experiences related to neurological changes in the brain, social, emotional, and cognitive impairment, health risk behaviors, disease and disability, and even death. So there's an incredible body of literature here. But what I want to really talk about right now are the neurological changes piece, because that's, if we think about what happens to kids when their brains are developing, that's really important for us to understand what happens in the brain. So let's start with the healthy brain, or a normal brain, which is, I'm going to use Paul MacLean's model of the triune brain. So it's basically, he's saying we've got 3 brains and 1 mind. And this is kind of an evolutionary model. So the brain stem is really, it's also referred to as reptilian brain. This is where our instincts come from. This is the part of the brain that makes sure our heart is, our blood is flowing, our heart is beating, and it keeps our bodies functioning. We don't have to think about what goes on there. Then there's the limbic system, or the emotional brain, and that's also called the old mammalian brain, and that's where all of our emotions get processed. And then there's the neocortex, the thinking brain, and this is the sort of the human brain. And presumably, right now, our entire brains are operating. Our brainstem is working because we're alive and sitting up, and there's some kind of emotional tone that you may or may not be aware of. but probably mostly what's on board right now is your thinking brain. So it's really top-down processing that's going on. You're really able to use that part of your brain, your thinking brain. But what happens when there's trauma, when there is this overwhelming, fearful experience? This is when we no longer have top-down processing, we have bottom-up. So the brainstem is now what is in charge of our functioning. So we go into an instinctive response. And it goes something like this. The amygdala, which is in the limbic system, that will register that something really fearful has happened and one's entire being is in threat. It may activate the social engagement system, so there may be attachment cry, a cry for help. But if it really is a life and death kind of threat, the sympathetic nervous system gets activated, and you're either going to want to run away, you're going to fight, or you're going to freeze, waiting for the moment when you can run. If there is not an option for that, then the parasympathetic nervous system kicks in, and there's a submit response, or feigned death. And those are all instinctive. We don't think about doing those. Our brains just propel us to engage in whatever makes the most sense in that moment. So structural dissociation is a model that has been well described by Vanderhart, Ninehouse, and Steele in their book, The Haunted Self. And so they talk about how trauma overwhelms the system and the psyche splits. And it splits into you have the apparently normal personality. Right now, we're all kind of functioning as normal human beings. So if we're trauma survivors, this is our apparently normal personality. If we have experienced trauma and there's this split, there's going to be a part of us that really holds the trauma and the memory. And those are the emotional parts. So here's the model. So the pre-trauma personality, no traumatic experience in one's life. You don't have the split between the A and P, the apparently normal personality, and the emotional parts. But if you've experienced a trauma, you do. So generally speaking, people can kind of function until something triggers the memory, and then the emotional parts get activated, and it may be any one of those 5 that you see: the attach, cry, the fight, flight, freeze, or submit. And each of those emotional parts has got its own kind of somatic experience, how you experience one's body. It has its own emotional tone, belief system, behaviors that are associated with it. The more you experience trauma, the more rigid or consolidated these parts become, the less fluid they are. And the more you experience, the more splitting you'll actually get. So and this is where we start to get into dissociative disorders, dissociative identity disorder, where there may be multiple aspects of the emotional parts that hold the fight instinct, or the flight, or the freeze, or any of these. So the more trauma there is, the more rigid these emotional parts are, and the more you will see. Research on the impact of childhood trauma on the brain has shown that for those kids who experience developmental neglect, there's an underdeveloped cortical and limbic system. So with neglect, they're not really taught how to modulate their emotions. They lack that capacity to kind of to calm themselves and soothe themselves. And of course, they're not really taught how to think and how to engage in the world. They're left to their own devices. With developmental trauma, the research shows that there's an overdeveloped brainstem. So, with that repeated life threat, that brainstem is working over and over again, and it becomes overdeveloped. And then, of course, if you have both developmental trauma and neglect, then your problems are compounded. I like this quote from Vincent Felitti, which comes from this book, The Impact of Early Life Trauma on Health and Disease, which is a great overview. So traumatic events, so they talk in this book about the hidden epidemic. Traumatic events of the earliest years of infancy and childhood are not lost, but like a child's footprints in cement, are often preserved lifelong. Time does not heal the wounds that occur in those earliest years. Time conceals them. They are not lost, they are embodied. So he's really saying we hold, trauma survivors hold the experience in their bodies. It comes out in physical health problems, in behaviors, in all kinds of ways. So just to summarize some of the gender differences that I've talked about so far, females are more likely to internalize distress, males are more likely to externalize distress, women are at greater risk of violence at home, and males are at greater risk outside the home. Women are more likely to suffer sexual violence, and men are more likely to be violent towards others and towards themselves. I just want to show this slide just to sort of start to talk a little bit about the impact on society in a very particular way, because I really want to zone in on this issue. And on this slide, the piece that I really want to highlight is the first section where it looks at victims who used health and social services. And here, you know, what's notable is that, again, we see this real difference between men and women in terms of their accessing health and social services. So women are far more likely to seek support in healthcare system or social service system. And then I just wanted to say something about the economic impacts of violence against women. So this is fairly recent data, and you know what we're seeing is that, and this is just about partner violence against women. They estimate billions of dollars in 1 year of the total cost of partner violence against women. And that's all we're talking about. And then the health costs of partner violence are 79 million a year. But if we expand that to look at, you know, what are the economic costs of interpersonal trauma, broadly speaking, it's a huge economic cost to our society, and not obviously just an economic cost. Okay, so let's now start to think about treatment for people who are dealing with complex trauma. And I want to talk about treatment in two different kind of categories of treatment. And one is trauma-specific treatment. So this is actually doing trauma therapy, doing sort of mental health work with someone, helping them to work through their trauma history. So that's trauma-specific treatment. And then there's trauma-informed care. So that is really addressing the fact that people with trauma histories are overrepresented in the healthcare system, and we need to think about how we are engaging with people who have trauma histories and what trauma survivors need in order to feel safe within the healthcare system. And actually not just within the healthcare system, but that's you know, what I'm going to focus on this morning. But let's talk first about trauma-specific treatment. And when we talk about treatment, we really need to address the issue of evidence-based practice. Evidence-based practice is the current paradigm for state-of-the-art care in medicine. I mean, this is what we are espousing to provide people who are seeking health services, is that it's evidence-based. We know we're offering them something that is going to work. And the aim, of course, is that we want to provide the best possible care with the least risk of harm. So what is evidence-based practice? Well, it's decision-making that's based on the best available evidence, as well as taking into account the patient, who the patient is, the kind of person they are, what their life situation is, and what they want. And it also recognizes that care is individualized and ever-changing. So it's not a cookie-cutter model. It's like you really need to take the individual into account in the context of the evidence. And then there's clinical expertise. You've got a clinician in there who's really helping the patient kind of understand what's available, and ideally, hopefully together, you make a decision taking into account all three: the patient, the research evidence, and the clinical expertise. So what counts as evidence? I think this is really important for us to understand. And here's the evidence pyramid. So basically, as you go up the pyramid, the quality of the evidence improves. So at the very bottom, we have this is when you don't have any research data, and all you can do is rely on experts. And that's, you know, and sometimes that's where we are, is that we have to rely on experts because that's all we have. And then you get the case reports, so individual cases, and then series of cases, and then more observational studies, non-randomized controlled studies, and then the randomized controlled trials, which is the sort of the gold standard of research design. And then at the very top are the systematic reviews. And the systematic reviews, ideally, are randomized controlled trials. So the best quality evidence comes from, according to evidence-based medicine, comes from randomized controlled trials. So those are. So it's a gold standard. To be randomized, to be a really high-quality RCT, randomized controlled trial, you need to clearly define your patient or client population. You need to know who you're studying. You need to be able to describe them because you want to know exactly who your evidence applies to. The intervention needs to be standardized and clearly defined because you want other researchers need to be able, and clinicians need to be able to know what the intervention was and be able to do exactly what had been done. You need to identify the outcomes really clearly in advance, and they need to be measurable. So they need to be identified in advance because if you did a trial and you decided to just that you're going to report on the one where you showed improvement, then it's not a rigorous trial by any means. You're really kind of just searching for evidence that's going to support what you want, what you believe. So you have to identify that in advance, and then you must control for any other variables that might explain or account for any change. So the advantages when you have a trial that's designed like that is that then you can actually draw causal conclusions. You can say that this treatment actually made a difference with this population to this degree. It eliminates random findings, findings that are purely by accident and not really representative of what an intervention does. By randomizing, you can ensure that your groups are roughly the same, and it typically will focus on pure diagnoses with no comorbidity, so that you really know that it pertains to this diagnostic group. So what are the disadvantages? Well, that it focuses on pure diagnoses with no comorbidity. So it's both good and bad. Well, what's bad about that? What's bad is that that's not the real world. So for example, if we take PTSD, it's a minority of people who just have simple PTSD. They're likely to have a whole bunch of other problems as well. Another disadvantage is that they're very expensive to do. So we don't see a lot of randomized controlled trials, and as a result. And because they're so expensive, the treatments are usually short-term, which is great when a short-term intervention is helpful for a population, but when you've got people with complex problems, and those of you who are clinicians working out in the field, I think you would agree that short-term treatments for complex trauma is not ideal. And then there are ethical concerns. So with randomized controlled trials, there can be real resistance to randomly assigning someone to get treatment and, say, a wait list group, or they're suffering, and is it really ethical to randomize? So where are we in terms of the best available research evidence for complex trauma? So the best available evidence that we have is all based on research that has been done for simple PTSD, which means that they've been brief interventions, and the ones that have the most evidence are CBT, cognitive behavioral therapy, prolonged exposure, and EMDR, eye movement desensitization and reprocessing. WHO recently released their guidelines for treatment for intimate partner violence, and they state that the recommended treatment for intimate partner violence is CBT or EMDR. So I would argue that someone who is suffering from domestic violence is probably suffering from complex PTSD. But that's the best available evidence that we have for trauma. So complex trauma is, as a result, it's understudied because these aren't pure diagnoses. And so we either extrapolate from the PTSD research, or we really need to go down the evidence pyramid and look at what other evidence is available to us. So let's talk about clinical expertise, that other ingredient for the decision-making process. And we have some real problems here as well. So if we look at clinical training programs, our training programs are emphasizing evidence-based medicine. It makes sense, of course, that you would want to teach evidence-based medicine, but it certainly is problematic for addressing what is a major problem, which is complex trauma. So students only learn these empirically supported treatments, and mostly it's CBT, and there's a bias against intensive treatments. There's a bias against psychodynamic treatments, and certainly novel treatments, such as sensory-motor psychotherapy, would never be taught or discussed in these training programs. And I want to actually come back to sensory-motor psychotherapy, as I think it presents a lot of, I think it's a great tool, potential to be a great tool. Then the other issue that is really problematic is that most training programs do not provide training in trauma treatment. So we have some really serious problems in terms of being prepared to address the treatment of trauma, which is a major problem in our society. So where does that leave clinicians? Well, they probably haven't been trained to work with trauma. There's more likely than not going to be pressure to provide brief interventions. The healthcare, if you're in a hospital program, there's going to be an emphasis on brief interventions. If people have private practice, insurance is it's going to be very time limited. And so it's really only those with the deep pockets that are able to afford the intensive treatment that they need. And also when it comes to working with complex trauma, many clinicians will say, that's too complicated, I don't understand, and so they don't want to treat these individuals and are looking for referrals. We see that all the time at our program. So it's a real problem that we have in addressing this issue. So there we are. We've got our best available evidence, research evidence, based on PTSD, if we insist on using RCTs, and our clinical expertise is I think, a little on the weak side. So what I wanted to show here in this slide is going down the evidence triangle to expert opinion, and I really think that that's pretty much where we are at this point with complex trauma. This is taken from a paper that they surveyed experts in trauma, and they asked them about their opinions about appropriate treatment of complex trauma. And these are the highlights. So complex trauma requires complex treatment. It requires longer term treatment. So those 6 to 8, 12 weeks are not sufficient. We need to provide a range of treatment modalities. So individual treatment, group treatment, family treatment, dealing with substance abuse, couple therapy. And then the continuity of care. I mean, that's a really critical piece, is that if you think about people who have these histories of complex trauma, the world is unsafe. And if they're going from one provider to another provider to another provider to another, it's like the ability to establish a safe connection is really impaired. So they really advise a continuity of care. So just going back to what I was saying earlier about the brain and the experience of trauma being embodied, I want to pose this question for all of you, which is that if the wounds of trauma are embodied, should treatment include a focus on the body? And that is something that, I think we're just beginning to recognize. And here's my chance to tell you about sensory motor psychotherapy. Sensory motor psychotherapy, I'm presenting it as a novel treatment, but in fact it's been around for about 20 years, although in the last few years, more and more clinicians are being trained in sensory motor psychotherapy. I'm one of those people. It's a very powerful tool. So what it does is it incorporates a bottom-up with a top-down approach. So it's really paying attention to what goes in the body, paying attention to somatic experience, and relying heavily on mindfulness. And I'm sure that we're all hearing so much about mindfulness and the benefits of mindfulness. Mindfulness is a key ingredient for doing sensory motor psychotherapy. So the aim of this approach is to actually change activation in the lower part of the brain, so that people who have trauma histories, they're so reactive, and sensory motor psychotherapy helps teach the client how to calm their bodies down. It really is based on this idea of neuroplasticity and using mindfulness. So we know now that the brain can change, and the bad news is that trauma has impacted the brain, but the good news is that we can still change the brain. But mindfulness is actually a key ingredient it supports neuroplasticity. So it activates a part of the brain that allows the brain to change. We've done some research in our program providing in fact, this is the very first bit of empirical evidence for sensory motor psychotherapy, I'm proud to say, but it is one of those, it's one group, but I think we had 10 women in this group, but with that group we were able to show that women were able to have a better sense of, have a heightened body awareness, which is an important tool for using the body as a resource for calming and centering and grounding. And we've done actually now a pilot RCT, and we will be hopefully writing that up for publication very soon. But we're just beginning to gather evidence to support this form of treatment. So, but where does this leave us? As we step back and look at the big picture, well, I think what it means is that too many women are not getting the treatment they need. And as a result, there are too many women in our society that are handicapped by their trauma history and are marginalized because of that. Okay, so now let's talk about trauma-informed care. So when we think of, what the world view, the experience of that the trauma survivor has of themselves and others, let's kind of paint that picture. So there's a sense of powerlessness, a lack of control. They're damaged goods. They're not worthy of being cared for. The world is unsafe. Authority figures are frightening. You can't trust other people. So this is kind of the mindset of someone who's then seeking care within the healthcare system. So what's going to happen? So here's some not uncommon presentations. It's going to be a lot of appointment cancellations because they get frightened and don't show up, or they don't adhere to treatment, and it may be because they actually couldn't even take in the information because they were so activated. A fear of common medical procedures, which is also going to feed into them avoiding appointments, not going for regular checkups, or they may excessively use the healthcare system, there's research that shows that there's an overuse of emergency departments. So they only go when they have to, when it's really kind of a desperate situation. They're mistrusting, they're easily triggered, not connected with, they can't really report very well on what's going on in their bodies, which is a bit of a problem when you're seeking health care. A lot of fear and agitation, they may be angry, difficult to work with, not able to speak up for themselves. They'll come with addiction and maybe frequently assaulted. It may be clear that they're engaging in self-harm. So those are the folks, that's not an uncommon presentation. And what do healthcare providers think about people like that? Well, they probably blame the patient. They just needed to kind of behave differently and take care of themselves. So we will kind of really want them to comply with our treatment. It's like that, we have a heavier hand because there's this desperation to get them to do what we want them to do. And so then there's this misuse and overuse of power, which altogether, that is another form of re-traumatization, that women will come away from those experiences feeling traumatized. So that's why we need trauma-informed care. And Sandra Bloom is one of the luminaries in the field of trauma-informed care, and she defines it this way: it's care that is grounded in and directed by a thorough understanding of the neurological, biological, psychological, and social effects of trauma and violence on humans, and is informed by knowledge of the prevalence of these experiences in persons who receive mental health services. Well, I would expand that to receive health care services. So Fallett and Harris are also individuals who are major figures in the field of trauma-informed care, and they have talked about 5 guiding principles. So, and they are creating a sense of safety, creating an environment where the patient, the client feels safe, being trustworthy, having a relationship where the individual actually feels that they can trust the provider, providing choice, collaborating with the client or the patient in what would be the most helpful thing for you and what would work for you, and empowering the individual. So those are the 5 guiding principles that they outline. And then there's this document which is also another way of describing trauma-informed care, but they talk about principles of sensitive practice. And this is a Canadian publication, and I highly recommend that you go to that. I provided the link on the slide, because you can download this, and it's a fantastic handbook. And it describes, it'll give you great background, but also really clear examples of how, what works and what doesn't work in working with individuals who have trauma histories. So providing respect, taking time, and that's a real, this is, at the service level, it's going to cost us a little bit more because we have to maybe not see so many people, we need to take more time, but in the long run, the economic benefits are going to far outweigh that. Establishing rapport, sharing information, sharing control, respecting boundaries, fostering mutual learning. We learn from they learn from us, and we learn from our clients. Understanding that healing is nonlinear, so people may seem like they're getting better, and then they come into your office and it seems like they've taken a few steps back, and that's normal. That healing is nonlinear, and that it's really important for us to demonstrate that we have an awareness and knowledge about trauma and its impact. So this is a great quote from that book, where this individual really makes a case for why, in fact, this needs to be universally applied. So here's what he says: because otherwise you're going to have a certain segment of patients that are going to walk away feeling as though they've been abused all over again, quietly abused, just walking away and seeking another healthcare practitioner, just going through the cycle again and again and again. And maybe not understanding why, maybe not knowing how to say it, how to voice that, just keep going through that whole cycle over and over again. There's a huge populace out there that just needs that extra gentle care. It's because of that maybe the whole populace needs to be treated the same way. So, to conclude, here are some of the take-home messages. Trauma, I hope that I've convinced you it's a pervasive and a complex problem, that we need to raise awareness about the prevalence of trauma and the impact of trauma. We need to incorporate training about trauma across all disciplines and not just health disciplines. Also our social services, our penal institutions. We need to lobby for funding, for research on best practice for trauma, looking at its cost effectiveness. We need to commit to addressing the root causes of interpersonal violence. And we need to apply the necessary resources to help victims heal. So my title, Everybody Hurts, is Everybody Hurts is an REM song. And I just want to leave with these final thoughts. We are all connected. Trauma impacts us all, whether it be a personal experience or knowing someone who has been affected. Trauma reverberates through the family and into the community. It affects our healthcare system, our social welfare system, our penal system, our economy. Until we address this problem at all levels, we all suffer. Thank you.